Yasir,
You
are
can go.
you recording this?
I'm recording.
All right, great. So I'd like to welcome everybody on the call to this lecture series for the Sudan Psychiatry Board in support of the from the UK and Ireland Sudanese physicians and from our own Dr. Yasir Mahjoub here in the US. I have the distinct pleasure today of introducing Dr. Edward Silberman, who is a professor emeritus at Tufts University, and who is, as maybe few of you have heard already, we have a very strong relationship in that he was my training director when I was a resident. So Dr. Silberman had a very varied and diverse career. He's received his BA from Yale and went to medical school at Tufts. Afterwards, he trained at Massachusetts Brigham and Women in psychiatric residency. And he had a DuPont Warrant Research Fellowship. If you look at his overall career, he was ambitious enough to try and be the complete psychiatrist. He did a lot of biological psychiatry training, a lot of research, and published some along those lines. He also trained in Philadelphia at the Psychoanalytic Institute and became a psychoanalyst. So he satisfied both the psychotherapy side of things and the biological side of things. If you look at the list of his publications, they span both with an emphasis on phenomenology, on anxiety disorders, on education. He moved on to education and took posts in both Tufts University, where he's currently a professor emeritus, but before that also at Pennsylvania Medical College and at Jefferson in Philadelphia, where I had the distinct pleasure of being trained by him. Dr. Silberman instills in you critical thinking. He also really instills in you to be true to your values, to look at the patient, and to respect the evidence. The topic that he will be presenting here today is, in the United States at least, the prescribing of benzodiazepine has veered greatly into an area where it does not respect the evidence anymore. There's a lot of fear and stigma around it. And Dr. Silberman has, over the past few years, been extremely energetic at re-educating all the physicians and the medical community about the proper use of the benzodiazepines. I think with no exaggeration whatsoever, you would find that what you're about to hear will add tremendously to your practice and to your knowledge base. So without further ado, Ed, I'd like to welcome you, and on behalf of all of us, thank you so much for making the time to teach us about this topic.
Thank you so much, Luai. So let me try to get this. Here we go. Okay, here it is. So we're going to be trying to talk about the place of benzodiazepines in treating anxiety disorders. And I want to start with a brief overview of the history of benzodiazepines. They were first introduced in the 1960s, 1970s, and they were really the first widely marketed psychotropic medications. Before that, there were psychotropic medications, chlorpromazine, for example, but this was for a very special population of very sick, psychotic people. But benzodiazepines became a mass market phenomenon, and their liabilities, because as all medications, they have some liabilities, were minimized by everybody. And they were prescribed very widely and very loosely for anxiety-related complaints, and probably prescribed more often even by primary care physicians than by psychiatrists. And so many people who had vague complaints, perhaps life stress-related complaints, were prescribed these with vague instructions, with, I'm sure, quite a variety of unrealistic expectations. And nobody worried about it too much for a while. And in fact, the benzodiazepine use became a national joke in the United States. There was a movie that came out in this era where one of the main characters was having a panic attack in a department store. And he looked around and he says, "Does anybody have a Valium?" And everybody in the department store reached into their pocket and pulled out a Valium. So that was how benzodiazepines started. Then, in the next decade, it became clear that there were some liabilities. For example, it became clear that in many people there was some degree of a benzodiazepine withdrawal syndrome, which in extreme cases could be severe, usually was not, but people became concerned. It also became clear that some people abused benzodiazepines. Now, who those people were, I think, has been a matter of continued confusion, although the data are very clear, and I'll talk to you some about them. Benzodiazepine withdrawal programs showed very high rates of taper failure. On the whole, about a third of people who were trying to get off benzodiazepines couldn't do it, or at least not via those protocols. And that is a whole story in itself, and it alarmed people even more. At the same time, I think as we were discussing just a few minutes ago, the pharmaceutical industry abandoned benzodiazepines and in favor of antidepressants. And there's very clear data that shows now that not only have benzodiazepines become stigmatized, but anxiety disorders themselves are somewhat stigmatized in that they are underdiagnosed and in many cases erroneously called mood disorders with anxiety. And so the impact of marketing has been profound, and benzodiazepines had nobody to stand up for them. Nobody was being paid to stand up and talk about benzodiazepines. And finally, benzodiazepines, their prescribers and their users became stigmatized. And then finally, the opioid epidemic hit, and combined use of opioids and benzodiazepines was seen to be quite common and very dangerous. And in the minds of many clinicians, it became a simple matter. Benzodiazepines and opioids are no different. I had someone, not a physician, but actually a member of my family, in a conversation the other day, referred to benzodiazepines as narcotics. I said, wait a moment, benzodiazepines are not narcotics. Where do you get that idea? But it's very pervasive. And evidence-based thinking faded to be replaced by fear-based thinking. So here is my summary of the prevailing dominant beliefs about benzodiazepines. They're effective anti-anxiety agents, but never use them for long-term treatment, never use them as first-line treatment, never use them for people with a substance abuse history. They're addictive. They cause dependence, whatever dependence is exactly. And if you can avoid them altogether, you absolutely should do so. And there are clinical institutions, at least in the United States, where it is forbidden to prescribe a benzodiazepine to people. So what's underlies these ideas? Well, first, the idea that benzodiazepines induce euphoria. They induce a high. Second, that benzodiazepines are primary drugs of abuse, that they're gateway drugs. They lead to abuse of other substances, that they're prone to tolerance and dose escalation. And former substance abusers prescribed benzos will either relapse on their substance or they'll start abusing the benzodiazepines. And finally, withdrawal from benzodiazepines is usually difficult and dangerous. And I will tell you now that there is no scientific evidence for any of these things, and the evidence is all in the opposite direction. So what I want to take just a slide or two to give you an idea of what the evidence base actually consists of. So there is a vast literature in animal studies from the 1970s, 80s, somewhat 90s. There's a substantial literature from clinical trials in anxiety disorders, some of which, of course, led to FDA indications for these drugs. Then there's a substantial literature about polysubstance abusing populations and what they tend to do in terms of adjunctive drug use. And then there's a literature on withdrawal. People who seem to have chronic, severe benzodiazepine side effects just from taking the medicine, not even withdrawing, or from withdrawing from them. And the literature there is much smaller. It consists of formal withdrawal studies, online conversations amongst benzodiazepine support groups, or as they're sometimes called, benzodiazepine survivor groups. And there's virtually no systematic study or scientific literature at all about people who experience these chronic, severe side effects, who they are, what those side effects mean. It's a very hard thing to study, and I don't want to get too far off on that tangent because that could be a talk in itself. So let's talk about some of the specific issues. Abuse and misuse of benzodiazepines. Benzodiazepines are very rarely sole drugs of abuse. They are adjunctive drugs taken along with opioids, alcohol, cocaine, either to enhance the high or to moderate unwanted aspects of the abused substance. Most misuse of benzodiazepines, and misuse is defined as using a medicine other than as prescribed. And we know if you look at all medicines, only 50% of patients on average do use them exactly as prescribed. So misuse of all medications is very common. Misuse of benzodiazepine occurs not to get high, but for patients who, for one reason or another, often poor prescribing, are attempting to control anxiety symptoms. And that's a very different goal than to get high. And these are people who are trying to function better, not trying to avoid functioning. And there is no evidence that prescribed use of benzodiazepines leads to abuse of other drugs. People who abuse only benzodiazepines, maybe it's 1% of the substance abusing population. Now, this Woods et al. Reference is a vast paper written by 3 pharmacologists, not psychiatrists, and it looked at something like 2,000 references in animal and human studies. And the synthesis of this was that neither control nor anxious subjects show reliable preference for benzos over placebo. So what that says in plain English is that if you give a benzodiazepine blindly to an average person who might be a patient, they can't distinguish it from placebo. I have to say, I've on a few occasions in life used a benzodiazepine for one reason or another, and I wouldn't have been able to distinguish it from placebo either. Just you don't feel a high. Sedative abusing subjects do show some preference for benzodiazepines over placebo. Benzodiazepines do not generally maintain their own administration in animal studies. That is the central characteristic of an addictive substance. Can you get, for example, an animal to work to self-administer the medicine? If you can, then this is an appetitive medicine that is prone to abuse. Very, very hard to get animals to work at all to self-administer benzos. And the pattern of reinforcement, even if you do, is very distinct from opioids, cocaine, alcohol, and for that matter, sugar. There's a study of a couple of decades back showing that sugar was more self-reinforcing than cocaine. 2001 review of the literature by Posternak and Mueller. Former substance abusers show no tendency to misuse or abuse benzodiazepines prescribed for anxiety disorders, nor do they show any tendency to relapse or to abuse other substances. So that this, I would say, close to 100% firm belief that if you have a past history, I'm not talking about being a current active user, but you have a past history of substance abuse, God forbid you should be prescribed a benzodiazepine. When I first got into this area, because I had someone referring to me a number of patients who had been in a research protocol at the University of Pennsylvania, I noticed that there were people with past alcohol abuse histories, no problem, no trouble, no dose escalation. They were absolutely stable. These were mostly people who had panic disorder. My favorite story about this issue is a woman who was a previous heroin addict. I suspect that she was trying to treat her anxiety attacks with heroin, but she was a former heroin addict. I could never get her to take as much benzodiazepine as I was prescribing. I kept saying to her, I don't think this is enough. You're not, you're still getting some panic attacks. No, I don't want to get hooked. So my clinical experience goes along completely with Posternak and Mueller's review of the literature. Tolerance. There is an incredibly widespread idea that people inevitably escalate their dose of benzodiazepines and become tolerant. This has never been described either in naturalistic follow-up studies or we now have one long-term double-blind placebo-controlled study. Tolerance does develop to the sedating effects and probably to the psychomotor effects of benzodiazepines. And that's a very important distinction because among other things, it means that benzodiazepines are not a good long-term sleeping medicine unless the reason the patient has insomnia is anxiety. And of course, there are plenty of people like that. In those cases, it will work indefinitely because what you're treating is anxiety. You're not just making the patient sleepy with a medicine, but otherwise, it is not a good sleeping medicine. So here's the 3-year random controlled trial of clonazepam versus paroxetine for panic disorder was done by Antonio Nardi and his group at the University of Rio in Brazil. Initial dose of paroxetine, 40 milligrams, unchanged. After 3 years, initial dose of clonazepam, 2 milligrams, similarly unchanged. After 3 years, about the same proportion of both groups were panic-free, very high proportion at the end of 3 years. But if you look at the bottom line, you will see the most typical difference between benzodiazepines and SSRIs, and that's intolerability. Adverse events for clonazepam, about 29% versus 70% for paroxetine. And that's what you always find whenever you look and whenever you prescribe. This is a new slide that I just put in, and this is the Rosenquist study that I just referred to. This is a Danish National Prescription Registry of over 4 million people. They looked at 20 years of data. They found that about 15% of people who were prescribed benzos used them for over 1 year, and 3% used them for over 7 years. Of those people, only 7% of the whole group escalated their dose at all, and dose escalation was strongly associated with a substance use history. So that goes back to the other slide that showed that people with a substance abuse history can tell the difference between benzos and placebo. So that people with no substance abuse history, there's virtually no dose escalation. It is remarkably low. And there are at least 10 other studies that show the same thing. And there are no studies that show the reverse. That's the evidence. Benzodiazepine withdrawal. Clinical experience is that it's not severe and it's not dangerous for most people. And there are many non-pharmacologic factors that play into this. I'll talk about it a little bit later, a little bit later. But certainly the alliance with the patient and the agreement about withdrawal is an enormous and important factor. The estimates for withdrawals, having a withdrawal syndrome at all, are very wide range. They go from 20% to 80%. There are some old withdrawal studies from maybe the 1990s that showed that even with abrupt withdrawal of benzodiazepines, only about half the people had a withdrawal syndrome. Seizures are rare. They're usually associated with high dose or intravenous benzodiazepines, but there really are no good data on prevalence. And very importantly, the studies on benzodiazepine withdrawal provide very little, well, they provide no information. I've never found a single one that had any information about why the patients wanted to withdraw. Some of them talk about indications for having been prescribed, and they're extremely broad, including a number of things that are just inappropriate for benzodiazepines, including depression, life stresses, but there's nothing about why the patient wanted to withdraw. And that, of course, is a crucial issue, but it's very unsystematic literature. There are anecdotal reports of these severe or prolonged withdrawal syndromes. Some of them have been published, and they are mostly surveys of people, for example, recruited from these online support groups who have had these problems. So it's not an epidemiological sample. It's a sample of people who said, yes, I've had terrible trouble getting off these medicines, and we don't know anything about their past history, why they were prescribed, how did they do, what was the treatment like? Were they prescribed by a primary care doctor who said, I'll see you next year? Or were they followed up closely and thoughtfully the way we would hope to do as psychiatrists? No information. So here's something that is frankly my assessment and my opinion, and we don't have good information. We don't have systematic data about this. I think that prescribing for inappropriate indications increases the risk of poor outcome, poor prescribing, and misuse. So an inadequate prescription leads to a misdiagnosis of abuse. Unrealistic therapeutic targets lead to inaccurate perceptions of tolerance, and arbitrary withdrawal of successful treatment leads to confirmation that the patient was dependent and has an unmanageable syndrome. I want to see if I had, no. So let me talk a little bit about that. I think that if you are prescribing for example, people who come in saying, my life is very stressful right now, can you give me something? First of all, these are going to be people who are likely to have a high level of maladaptive personality traits, and no medication is going to address those. But as we know, as prescribers, these very same people are somewhat resistant to looking at themselves and trying to deal with their own maladaptive behaviors. They would like a magic pill to make them feel better. And so you get into a situation where people are hopeful that they will get an emotional anesthesia from the doctor, and they will be able to cope with everything better. And of course, that never happens. And so you can imagine what a group of people with a degree of personality pathology might do in a situation where they have been inadequately educated and inadequately monitored. So that's number one. Inadequate prescription leads to a misdiagnosis of abuse. Well, physicians who prescribe inadequate doses with reluctant and suspicious comments to the patient are likely to produce a situation where the anxiety persists. If you are underdosing a population of anxious people, they're going to react in an anxious way. And one of the most common things they might do would be, well, this isn't enough, I'll take some more. And so then they take some more, and they may even take more than they should, and then they have a mini withdrawal, and that causes a rebound of the original anxiety symptoms, and they don't understand what's going on at all because they've not been educated about any of this. And so they make a panicky call to the doctor saying, I'm not getting enough of this medicine, I need more. The doctor then becomes very panicky and says, oh my goodness, I knew I shouldn't have prescribed this stuff in the first place. And the entire treatment falls apart. And what is actually misuse on the part of the patient, which is use for the purpose of doing better, rather than abuse, which is used for the purpose of avoiding functioning. It's a distinction that completely gets lost. And the doctor then is reinforced in his or her idea that, oh, look how these medicines cause problems. Unrealistic therapeutic targets. This is the issue of the emotional anesthesia. There are a certain population of people who, in asking for something, really are not asking for treatment for focal and specific anxiety symptoms, they are asking for emotional anesthesia. So what typically happens in those cases? Well, you prescribe a benzodiazepine. Let's say you prescribe 1 milligram of clonazepam twice a day. Well, that will have some effect. Benzodiazepines don't make people high, but they do blunt affect some. And so people will feel, oh, yes, doctor, this is helping some. Then in another 2 or 3 weeks, it will become clear to these people that the result is relatively subtle and that it is not doing what they hoped it would do when they came in. And so they ask for more. Well, this is helping, but I think a little more would really help even more. And this creates the illusion of tolerance developing. In fact, tolerance is never developed. What's developed is a growing distance between what the patient wants and what the medications are capable of doing. But again, this reinforces these common misconceptions. And finally, I have seen this over and over again. I've gotten calls from people all over the country. I've been involved in legal cases that have to do with this. There are people who have been doing well, sometimes for a decade or more, on stable doses of benzodiazepines. A clinician says to them, oh, you're dependent. You have to get off this medicine. What sense does that make? Would anybody say that to somebody taking digitalis? Would anybody say that to somebody taking thyroid medication? But if it's or for that matter, antidepressants, you're dependent. So these people are essentially punished for having done well on a medication. Well, how is the withdrawal possibly going to go well under those circumstances? First of all, it's an involuntary withdrawal. Secondly, it's a withdrawal in a person with an underlying anxiety disorder. And third, it's a withdrawal of a person who's prone to be anxious. So can you imagine how that all goes? And these people don't do well. So I want to show just a few slides talking about such studies as there are that compare the efficacy of benzodiazepines versus antidepressants. There are not very many head-to-head studies, and most of them are actually with older tricyclic medications, again, for the reason that who can get funding to do benzodiazepine efficacy research these days? These were done in the days when pharmaceutical companies were willing to fund such studies, as well as the federal government. And that's, by the way, why a lot of the evidence base is a little older, because until recently, there does seem to, in the last 5 to 10 years, been a little bit of an uptick in benzodiazepine research. But most of the literature is older, because how is anybody going to do it? There's no support for it. In any case, here are some studies in various disorders, starting with mixed anxiety disorder. 2 studies comparing tricyclics to benzodiazepines showed that tricyclics were a bit better. 1 study showed that the benzodiazepines were better, and 1 study showed them to be about equivalent. In generalized anxiety disorder, very similar picture. Benzodiazepines seem to be better for the somatic anxiety symptoms, and tricyclics for the psychological symptoms. In 2 other studies, they were about the same. In benzodiazepines versus tricyclics in panic disorder, the benzos were a little bit better, about 10% better. Benzos were about the same as MAO inhibitors. And by the way, MAO inhibitors are also a vastly underutilized class of medications. And they're very effective for anxiety disorders. Comparative efficacy of benzos and venlafaxine, there's one study comparing it in generalized anxiety disorder, about the same. And benzos versus paroxetine in generalized anxiety disorder, two studies showing benzodiazepines a little bit better. So I think a fair statement could be made about the very small head-to-head literature that on the whole, benzodiazepines seem to be roughly as effective as tricyclics and SSRIs, SNRIs, as far as we can tell. I'll show you a little bit of indirect evidence. A study in the Canadian literature looking at Canadian classification for first, second, and third line, according to them, for anxiety disorders. So their first line treatments typically were SSRIs and SNRIs. Second line treatment included benzodiazepines, and third line had more antipsychotics, neuroleptics. And this is what they found in terms of overall effects. Response and remission, SSRIs, 67% response, SNRIs, 68%, benzodiazepines, 57%, buspirone, 49%, pregabalin, 54%. So this is all first line, second line, and third line. The remission data are a little different, that benzodiazepines are a little bit better than SSRIs. But again, overall, this shows rough equivalency. On the other hand, the 2014 Harvard algorithm for social anxiety disorder, you remember the number needed to treat is the inverse of the response proportion. And so the lower the number needed to treat, the more effective the drug is. And here all the way at the bottom is clonazepam, with by far the lowest number needed to treat, a 78% response versus only 20% in placebo. And finally, meta-analysis of randomized controlled trials in GAD. You can see about roughly equal numbers of benzodiazepines and antidepressants. And the summary statement was benzodiazepines yielded the highest effect size, which was significantly larger than the effect sizes for SSRIs and SNRIs, regardless of the length of treatment. Effect size overall was about 1.5 times that of antidepressants. I have to say, and this is just my non-systematic experience, that these last two slides more reflect my own clinical experience. That for many patients, not for all, not everybody is even a good benzodiazepine responder, but on the whole, I have found these to be more reliably effective for anxiety than antidepressants. But let's say they're roughly equivalent. On the other hand, here's some data from a relatively recent publication by Qualiato and colleagues comparing side effects of benzos versus SSRIs in a population of panic disorder patients. And here there's really no comparison. The only dimension on which benzodiazepines had a higher propensity to side effects versus placebo was somnolence. And as we know, that's short term, that's temporary. Everything else, including, I think we really need to look down here, including this one, the SSRIs fared worse. This is, again, a meta-analysis. So, everybody talks about the terrible cognitive effects of benzodiazepines. Benzodiazepines do have cognitive effects, but for the average non-geriatric person, these are laboratory level. You can demonstrate them, and sometimes they're long-term. They fade slowly, and it's not clear if they fade completely even over time when you stop the medicine, but patients are not aware of them. They're subtle and they're not handicapping. And of course, there was that scare about dementia and benzodiazepines, which is now been debunked. But the antidepressants look a lot worse. So benzodiazepines are very reliably more tolerated than the variety of antidepressants. So I will close this with a few words about prescribing and prescribing guidelines. Good indications for benzodiazepines are panic disorder, social anxiety disorder, mixed anxiety disorders, including anxiety disorders that have some obsessive compulsive symptoms, but are not pure culture obsessive compulsive disorder. Benzodiazepines are not very effective in that, but if you have people who have, say, some generalized anxiety or social anxiety, and they also have some obsessive tendencies. For example, I had a patient who was a nurse, and he had great trouble getting out of the hospital on time when his shift was over because he had to compulsively read and reread his notes to make sure he hadn't made any mistake. It's an obsessive compulsive symptom. Responded perfectly well to a modest dose of benzodiazepine. Generalized anxiety, and of course, this is the one that it's most famous for, but I think, ironically, this is the one you have to be most cautious about, and I'll come back to this. And then diagnostically uncertain mixed depression and anxiety. I'm sure we've all had patients, I sure have, who were both very dysphoric. They would complain of low mood, and they were very anxious. And sometimes it's extremely difficult to tell what's primary. Is this anxiety in someone with a primary mood disorder, or is it secondary dysphoria in a person with a primary anxiety disorder? I would contend that in this population of patients, it makes much more sense to start out with a benzodiazepine rather than to do what the vast majority of psychiatrists would do and start out with an antidepressant. Why? Because with a benzodiazepine, you'll get an answer in a week. The patient, they work right away. The patient will either say, oh, I feel a lot better, and be able to describe in just what way they feel better, or they won't. And if they don't, then your index of suspicion for a primary mood disorder should be a lot higher. If you start with an antidepressant, you are buying a 6-week trial. And if the patient does not respond very well to that 6-week trial, you're probably obligated to run at least another 6-week trial, because we all know that not all depressed patients respond to the same class of antidepressants. So you are into weeks, if not months, of clinical trials with medications that have a worse side effect profile than something that you could get an answer from in a week and is very well tolerated. If you can make a good case for not doing that, I'm willing to listen, but I haven't heard one yet. Contraindications. Certainly, patients currently abusing substances should not be prescribed benzodiazepines. Elderly patients, now, this is not an absolute contraindication. We know that the risk for various side effects, including cognition and motor coordination, are higher in the elderly. My colleague in Boston, Carl Salzman, who has done a tremendous amount of research about this, especially in geriatric patients, educated me that very often, if you have a geriatric age patient who has done well previously on benzodiazepines and is having trouble getting off, lowering the dose very often preserves the therapeutic effect and minimizes the side effects. So, like with so many other medications in the elderly, the correct dose may simply be lower. Certainly patients with respiratory disorders, because we know benzodiazepines inhibit respiration, patients with cognitive impairment or coarse brain pathology, patients with poor tolerance for negative affect. These are the people that I was talking about who are looking for emotional anesthesia. You don't want to prescribe this for somebody who can't tolerate their own emotions, their own feelings, because it's too tempting to try to misuse. Again, I don't say abuse, but misuse them. I try never to prescribe benzodiazepines just because they act right away, and so anything that acts right away will be more reinforcing, and people with poor coping ability. So this personality disorder group, it's not an absolute contraindication, but one has to think twice. So here are the special considerations in generalized anxiety disorder. How do you define the goals of treatment? How much generalized anxiety is too much? If you're treating panic disorder, the normal number of panic attacks a year is 0. It's just clear. The normal level of generalized anxiety is not 0 because it's a normal affect. And the people who have 0 generalized anxiety, we call sociopaths. So how do you define a clear, workable target? There's a high rate of comorbidity. We touched on that. How much can a medication, an anxiolytic, treat? And then the high level of the comorbidity is both with other anxiety disorders and with mood disorders and the personality pathology, and how much can any medication treat? So I would propose the following as general benzodiazepine guidelines. Educate the patient at the outset about what the medicine is for and what it isn't for. And in particular, it's very good for lowering symptomatic anxiety. It is not nearly as good for dealing with anxiety-based cognitive distortions, and it's not good at all for dealing with avoidant behaviors, which are a huge part of the pathology in anxiety disorder patients. And so people have to know that, and they have to know what to expect. You have to give them clear target symptoms. How will we know if this is helpful or it isn't helpful? Benzodiazepines are perfectly appropriate for first-line treatment, often, I think, preferable. Adequate dosing, but not escalating dosing. So if people don't respond well to 1 to 4 milligrams a day of a high-potency benzodiazepine, alprazolam, clonazepam, lorazepam, they are not good benzodiazepine responders, and escalating the dose will not help and will only confuse the situation and create a problem of a longer taper to get off when everybody recognizes that the medicine isn't doing the trick. Standing doses, not PRN. Lots of clinicians seem to think that PRN is somehow more conservative, but it has many perverse effects. First of all, when you treat anxiety, just as when you treat pain, one of the things you want to do is to distract the patient, turn the patient's attention away from the anxiety to other things. If you prescribe PRN, you do exactly the opposite. The patient will walk around all day saying, do I feel bad enough to take it yet? How about now? How bad do I have to feel? With the implicit message, you shouldn't really be taking this, or unless you really, really need it. That focuses people on their anxiety. Then by the time they feel bad enough to take it, it's too late because it doesn't work instantly. So what you're trying to do with standing doses is preventive, again, and analogous to pain treatment, not to catch up once the symptom is raging. You're trying to do preventive treatment. And that is inevitably more effective. And so you say to the patient, if you're getting a good response, but maybe not an optimal response, we'll talk about it and we'll raise your standing dose. Don't take PRNs. Look for an unequivocal response. People who respond well to benzodiazepines will say, I feel better, and they will be able to tell you exactly in what way they feel better, and they'll look better. Be wary of equivocal responses because those may flag a poor responder, and it's very important to recognize those people and not just get into trying to escalate the dose to get a better response, because it won't. And then use a flexible taper if needed. A flexible taper means telling the patient, number one, there's no rush. Number two, here's a starting dosing taper schedule, but we won't go down to the next step until you feel comfortable where you are. And it's collaborative. I've never not been able to taper people down or off using that strategy. Finally, goals for GAD. A reasonable goal, I think, is to diminish anxiety to the point where it's no longer overwhelming to the patient. And the patient is then more available to use, for example, cognitive and behavioral strategies to help cope better and feel better. So that another way of putting it, I suppose, would be to reduce the anxiety to the point where the patient is either able to make use of their own personal resources better, or they are more available to use therapy effectively. Negotiate with the patient what is the criteria for success. Here's what we're trying to accomplish. Here's what we can expect. Here's what we can't expect. And make sure you get a clear statement from the patient of just what the medicine is doing, so that you know what it's doing and it isn't doing. Avoid progressive dose escalation. We talked about that, and emphasize the need for other methods to control anxiety. There are very few anxiety disorders that can be fully treated with medication alone. Some cases of panic disorder can, with a little informal encouragement to the patient to face feared situations, that they're not going to have panic attacks anymore. But other than that, people almost inevitably need something else, if nothing else, to break patterns of avoidance, which can be completely crippling, and the medication in itself will not do it. Finally, tapering benzodiazepines. The most important thing is achieving consensus about when to taper and why to taper. there has to be agreement between doctor and patient about that. And it has to be something specific to the patient, not some general idea like nobody should be on benzodiazepines long term. Educate the patient about what to expect. People's emotional responses to the same pharmacologic symptoms are enormously different if they know what to expect or if they don't know what to expect. And this has been demonstrated. This is a very old and famous finding in the psychology literature. Remove pressure of time, we talked about that. The flexible taper, and finally, because the patient experiences the taper logarithmically, not linearly, meaning that every time you take off another dose, the percentage change gets higher and higher. And so its highest, you finally will probably have to get to the point where your taper is 50% because you can't get a smaller dose of the medicine. And so you may have to go more slowly near the end and in smaller steps. And again, educate the patient, let them know what to expect, because otherwise their anxiety about it will escalate everything. Here's a little bit of a bibliography, which nobody can absorb, but just trying to demonstrate that I didn't make all of this stuff up. So that's my sermon.
Excellent, excellent. Thank you so much, Dr. Silberman. It's quite a tour de force. It feels almost like a corrective, kind of like what many of the ECT leaders like Max Fink and his group were trying to do to educate everybody.
I know very well how Max Fink must feel.
So it's a necessary voice, and we really appreciate it. I'm gonna open it up for questions. I think people would be raising their hands, and then I can just point at you and just tell you to go forth. I think the first hand I see is for Yasser. Go for it.
Thank you very much, Dr. Silberman, for the very interesting topic. I have comments and at the same time questions. So I think one of the major issues we're dealing with here is description in psychiatry. So when we describe basically an anxiety as a separate condition, we're forgetting that an anxiety is an affective component. It's has an affective it's a similar affective disorder. So depression doesn't always necessarily present separately as similar to a CIGI CAPS. The classical presentation is very heterogeneous, and it can present with a panic disorder. It can present with a generalized anxiety symptoms. It can present with symptoms similar to OCD. It can present with rumination, fixation. And again, I think the problem that we dealt with when we described depression, we expect it to be the CIGI CAPS, and then forget that these presentations are separate. We treat them as separate conditions and anxiety, yet they're depression. Or they might be depression. So that's what it's not. We see some. I've seen a lot of these patients who benefit a lot from benzos. They tend to have some anxiety component, regardless of how we describe this anxiety, panic, rumination, or so the other thing in here is, let's say we're coming across one of these very difficult patients with severe anxiety, irritability, restlessness, and then they benefit from benzos.
Mm-hmm.
And then you take the benzos away from them, and basically they have this recurrence of the same presentation. The problem when you call this, and not you call this a discontinuation presentation, or you call this basically addiction.
Yeah.
Well, just basically, you're uncovering the previous symptoms that was treated adequately with benzos. That's a problem in literature. We have not been able to to delineate.
Absolutely agree with you, and it's insane to call it an addiction. It's the first question is an interesting one, and there's a little bit of literature. Aaron Beck has published on typical cognitions that distinguish people with a primary mood disorder from a primary anxiety disorder, and what that boils down to is that people with a primary mood disorder are focused on the past, and they are focused on helplessness and the impossibility of change, of positive change. People with a primary anxiety disorder who may be equally dysphoric, both groups may report equally low mood. People with a primary anxiety disorder are focused fearfully on the future. What will happen? What will happen? What will happen? And so instead of the despair about the past, you have the fear about the future. A group of psychologists, this is an old study, published, again, a similar attempt to do a factor analysis on people who had, a large group of people who had mixed anxious and depressive symptoms. And what they found was that there was a common factor of dysphoria that didn't distinguish the two of them at all. The thing that distinguished the two of them most was the cluster of anxiety symptom of somatic symptoms that were associated with anxiety disorders, and much less so with the mood disorders. But this is really an issue, and I think that while you can expect antidepressants and benzodiazepines to be cross-effective in people who have either anxious depression or dysphoric anxiety disorders, it's a matter of degree, because the people with a real primary mood disorder, they may feel a little bit more comfortable when you prescribe the benzodiazepine, and sometimes it's recommended initially just for that. But in the long term, they're not going to get better. They're not going to do well. They're going to need an antidepressant. In the other direction, it's a little less clear, because as you've seen in the slides, antidepressants may have good anti-anxiety effect. And so that kind of biases everybody's diagnosis too a little bit.
I'll add one point before I go. I also came across several literature talking about the antidepressant effect of benzodiazepine, and these are the literature from the 70s, 80s until the beginning of the 90s. Not all like benzodiazepine had an antidepressant effect. So I came across this, like specifically it was adinazolam, alprazolam, and I think also Ativan, lorazepam. The rest, Valium, terrible. Chlorodiazepam hydroxide, terrible. But only specific, a group of them had some specific antidepressant. Not all of them. It's not a characteristic for the whole group.
Yeah, and that's an interesting and I think an understudied question too, because who would respond just that way? Now, alprazolam, of course, is a special case, because alprazolam is not just a benzodiazepine, it's a triazolobenzodiazepine. And I can tell you that in my own practice, I have seen 3 people become hypomanic from taking alprazolam who never had a diagnosis of bipolar disorder. They had the diathesis, they never knew it, and they became clinically hypomanic. Well, once you see that, you know that you have a medicine that has some antidepressant potential, because you don't see that otherwise. The other medications, I don't know. I don't know what to make of it. It's a very interesting observation. And that paper that you sent me, I read with interest, and I don't know who those people are. Most of them seem to have bipolar disorder, but maybe not all of them.
It always raises the question of phenomenology and how much we need to know more. Your discussion about alprazolam reminded me of what Alan Schatzberg and Jonathan Cole had written in their manual of clinical psychopharmacology, and how some of these benzodiazepines, in particular alprazolam and clonazepam, actually have some monoaminergic moieties, and they have action on those systems too.
Our psychotropic drugs are almost all very dirty. they all, they just do so many different things, and we never quite know what's operative.
Let's see if we have any other questions. Anyone wants to go? While okay, we do have a question from Muhammad.
Hello.
Hello.
I'm not sure whether I need to say good morning, good evening here. It's good evening here in Dubai.
Good
Thank you so
afternoon.
much. Yeah.
It's afternoon here.
Yeah, good afternoon then. And good evening to all other attendants. Thank you so much for the very informative and very nice talk. I have one comment. Are we talking here about anxiety like insulin dependent diabetic patients? There is anxiety dependent or benzodiazepine dependent anxiety patients here. You just mentioned that withdrawal symptoms in benzodiazepines are not that troublesome. Instead, it is about reinstitution of symptoms, anxiety symptoms when you stop benzodiazepines. So can we compare this to insulin-dependent diabetic patients?
I think it's probably much more complicated than that, because people can become dependent in a variety of different ways. And that's the problem with that word, dependent, because in people's minds, it's a synonym for addiction. And in fact, in ICD-10, they do call addiction dependence. But so, for example, if you take a medication for a valid medical indication and it helps you, you're therapeutically dependent on it. That's one kind of dependence. A second kind of dependence is that you believe you need a medication. You may or you may not, but you're afraid to go without it. And that's a kind of psychological dependence. A third kind of dependence is physiologic dependence, which has to do with the presence of withdrawal syndrome. And a fourth kind of dependence is the kind that everybody thinks of when they hear the word dependence, which is an abuse disorder. And they're not all the same. And so you have to take, I think, the patient one at a time and try to understand what is the role of the medication in this person's life. I mean, why do we not talk about dependence from venlafaxine, which has it's much harder for people to get off venlafaxine than it is for them to get off clonazepam, I tell you that.
Yeah. I think Mohammed, thank you for the question. I think he also highlights that question of those patients who are on long-term benzodiazepine prescribed, who actually are uniquely responsive to it, and they've ended up being on it, or you can call it dependency, but in that best sense, in the sense that it's medically indicated, in the sense that there are few things that have been tried. And many of us here who are inpatient psychiatrists see the horror show in earnest when you have a long-term patient who's been maintained on a dose of clonazepam for years and years. They retire, a new psychiatrists come on, they decide, okay, this is not good, they have all these problems with them, they discontinue them, and they end up coming to the inpatient site, where the only thing you actually can help them with is to reinstate that whole dose of benzodiazepine. So in that sense, I do think it's appropriate to link it to maybe insulin dependent in that sense, in the sense that it's medically indicated. Okay, we have a couple of other questions. I think the first was Abdulazim Ali.
Hello, hi. Thank you very much for this nice talk, Professor. It's really very informative. Yeah, I'm a consultant psychiatrist in addiction and general adult. It's just my question is related to the previous discussion about patient, because I noticed we have a lot of patients that can be maintaining low dose of benzodiazepine for a long time. And it's just, it just lead to the question, is it worth actually stopping this medication and just jeopardize their care and their treatment, or just continue on it? The other thing is that is it necessary for a patient taking low dose of benzodiazepine that at some point that they develop tolerance and dependence on this dose, then we need to increase it? Or is it because that's what we read in scientific books and research, is that benzodiazepine at some point you need to increase the dose because the current dose will not be effective. But in clinical practice, when I personally noted that some of or a few patients that can be maintaining just low dose of benzodiazepine, and it will be more enough for control of their anxiety.
I don't think you really read that in the scientific literature. You may read it in some textbooks of psychiatry and in guidelines, but it's just as I said, you've kind of answered the question yourself. You have seen a population of patients who have no tendency to escalate their dose at all. They're doing perfectly well. Now, there's a question of what were the original indications and what are you treating with it and all of that. But whatever that is, you see yourself, these people have no tendency to escalate dose. And there is no evidence that this is a problem. People do not lose the anti-anxiety effects of benzodiazepines. They will lose the sedating effect, but not the anti-anxiety effect. There is absolutely no evidence that this actually happens. All the evidence goes in the opposite direction. And so people continue to repeat this, even though the evidence is that it is not true. This is one of the most disturbing things about this phenomenon. So that's my best answer. Was there a second question, though?
I think this answers it in the sense that you mentioned the cardinal distinction between the issue of tolerance and that doesn't really happen. But I think he was asking also, would there be any indication of stopping at all in that patient population?
Yeah. Well, I would say in general, there are two. One is that there are many anxiety disorders that wax and wane over time. And so, and they tend to be rather irregular. So I think a reasonable person could say, every once in a while, you might make an attempt to, lower the dose and see if the person can get by just as well on a lower dose, or perhaps off completely, and see what happens. In the studies where people have done that, and the person who's done a lot of that is Carl Rickles at the University of Pennsylvania, he found that about 50% of people who had been on long-term benzodiazepines could stay off them. And the other 50% had a recurrence of anxiety, not necessarily immediately. We're not talking about withdrawal. We're talking about they get off completely, and then 3 months later, it comes back.
Right.
So it's reasonable to think about doing that if the patient agrees. The second thing is, are people having some kind of problematic side effects? We don't at this point have any reason to be afraid that you're going to cause dementia by prescribing this long term. And other things would be apparent. So if somebody is becoming a little confused or forgetful, then absolutely, if somebody is becoming overly slowed down or has coordination impairment, is having falls, then yes, then that's an indication. Then there are, of course, many other things that come up in life. Many people, women who want to get pregnant, don't want to take anything during their pregnancy. And so that might be another indication. But it's important that it be a specific indication about that particular patient. I have had patients who I've treated for a long time, and I've treated for long enough that they're getting into the geriatric age range. And I've said, you know, I think it would probably be better to see if you can get by on a little bit less than this, just because the risks get higher, and maybe you don't need this much anymore. And again, you have to get the cooperation of the patient. It will go well if you do, and if you try to force something, it won't. There are some, of course, there might be some conditions. If somebody is really getting confused or having falls, you might have to be more forceful and say, look, I think this medicine is contributing, and you have to at least try to be at a lower dose and see if you can tolerate it at all. But it's very, very important to maintain the alliance with the patient.
Thank you so much, Dr. Azim, for the question. We have two more questions. These Selma and Yasin. Selma, you can go first.
Hi, thank you, Professor Silberman, for this very informative topic. I work in rehabilitation services in UK, London, UK, Kent, actually. And I'm just interested in the indication. When we were discussing, where this was discussed, you mentioned that anxiety disorder that have obsessive compulsive symptoms. I'm just wondering if we have somebody with obsessive compulsive disorder diagnosed and treated, that has associated significant anxiety and panic attacks with his compulsions. Would the use of benzodiazepine, for instance, low dose clonazepam, be helpful? We have a recent admission with obsessive compulsive disorder and severe ones. He spent some time in the specialized obsessive compulsive inpatient services, and then discharged with fluoxetine, pregabalin, propranolol, and I think this is what I remember from his medication. But he significantly deteriorated over 6 months at home, and then admitted to us with these medications. I noticed last week that he was prescribed lorazepam, PRN. So I'm just wondering, would it be more beneficial to prescribe clonazepam low dose twice daily, for example, instead of lorazepam? Or what's your advice on that?
So this is a very interesting sort of case, and I think that in terms of trying a benzodiazepine, I would say there's no harm in it, especially for someone who's severely impaired and is not responding well to a variety of other treatments. Why not try it? At the very least, if the person is having panic attacks, there's no reason to think that because they have OCD also, that the benzodiazepine wouldn't work for the panic attacks. It's probably the best medicine known for panic attacks. I absolutely think that anybody with chronic or frequent anxiety should be on standing doses, not PRN, for all the reasons I discussed. The only time I prescribe PRN benzodiazepines is for people who have infrequent, predictable anxiety symptoms. The classic one being fear of flying, So you can say, okay, an hour before you get on the plane, take 1 milligram of Ativan, and because it's very clear, it's predictable, and it's relatively rare, or people who have to make some presentation at work and they have a fear of speaking in front of other people. That's a good PRN use also. But for anything that's every day, I think prevention is much better than trying to catch up. You want to prevent it. You want to stave it off, not to deal with it once it's troublesome enough that the patient feels it's legitimate to take the dose.
Great. Thank you so much,
Thank
Selma,
you.
for the
Thank you very
question.
much.
All right, and last we have, I think, Professor Yasin.
And good afternoon. Actually, I'm Yasin Ahmed Ali. I'm a specialist in psychiatry, and I work in Ireland in liaison psychiatry. I'm not the other professor.
I think I thought you were Yasin al-Gaddaf.
Sorry for the mistake. I have just two questions. As I mentioned, I work in liaison psychiatry. And thank you very much, Professor, for the very, very informative and eye-opening lecture. And as we are revisiting all the previously known as facts beyond discussion about benzodiazepine, I wonder what's your comment on the paradoxical effect of use of benzodiazepine, for example, giving it to patient to calm him down, and then you end up with the opposite, because it's also a kind of a limiting the practice. Most of physicians and psychiatrists, they try to avoid using it in the acute setting to avoid getting into this situation. This is the first question. The second question also, what about the treatment of benzodiazepine in patients with epilepsy and comorbid anxiety? Does it also, do you come across any studies that they say it has like superiority in this condition or not? Thank you very much.
Right. So I want to make sure I understood your first question properly, because you were breaking up a little bit. Were you talking about the paradoxical disinhibition reactions in benzodiazepines?
Yes.
Yeah. I have to say that this is something that is talked about a great deal more than it is ever seen. There is some literature about it. There are some reviews, and generally when this occurs, it tends to occur either in very young people, in kids, or in older people and other people who have some kind of compromised brain function at baseline. Who have coarse brain pathology of some kind. That those are the people, when you see the paradoxical reaction, and there are really no good epidemiological data about it that I've ever seen. So it's hard to know what percentage is, but I have to tell you, I've never seen it in my own clinical practice. But it's usually in one of those two groups of people, either in kids or in people with compromised brain function. And otherwise, I don't, it's, people fear it quite a bit. What I've mostly seen is that in agitated psychotic patients, benzodiazepines can be very useful adjunctively. So that's question number one. Question number two, I don't want to tell you more than I know. The problem with benzodiazepines in epilepsy is that they work well acutely, and they're useful, for example, bringing people out of status epilepticus, but they don't seem to work well chronically. And so, again, I don't know that they would be harmful. Ideally, of course, if you had a very anxious person who had a seizure disorder, they might turn out to respond well to an anticonvulsant medication and only have to take one medication. If they don't, probably taking a benzodiazepine will not relieve them of the need to take an anticonvulsant as well.
For the paradoxical excitation, Yasser had posted in the chat that he had seen this term being given to a delirious elderly patient or a catatonic patient when the effect of the lorazepam is wearing off.
Yeah, interesting. Yeah, I certainly would not give benzodiazepines to anybody who had delirium.
Yeah.
Catatonia is a different story, and then it's usually a question of not giving enough benzodiazepine.
All right. Are there any more questions? We're ready to wrap up. Okay, I don't see any. So, Dr. Silberman, thank you so much again for this extremely informative talk and for really, I think, doing a corrective and giving us ammunition. Many of these slides, I must say, the question of tolerance, I don't think I was aware of that. I took it for granted that it is. That meta-analysis where you actually see the actual number of the cognitive dysfunction rate is great ammunition. And just the overview of the indications itself and the contraindications. So lots of material for us to work with. So really, really appreciate it.
Thank you so much for the opportunity to speak to you. This is a great privilege for me too, and it's wonderful to see you. Why this was a great treat and surprise.
Likewise, yeah, it's amazing. Well, I want to thank everybody for their attention as well and for your time, and hopefully this was beneficial. It's going to be recorded, so you'll have a chance to view it at a later time. Feel free to share it widely. This is an extremely important topic that I think you'll help a lot of people to prescribe benzodiazepines correctly. Benzodiazepines are among the most important agents that we have, and using them correctly is really extremely beneficial to our patients. So have a good afternoon and evening, everybody, and thanks again, Dr. Silberman. Lovely to see you.
Take care.